And now, Dr. Marie Benner, Senior Public Health Advisor of Malteser International, so another one of our German WASH Network members, will be speaking. She's been with Malteser International since 2012, former Regional Health and Nutrition Coordinator at DG European Commission Humanitarian Aid Office ECHO in Thailand, and we look forward to your presentation.
Thank you very much, Thilo. Good morning, everyone. It's wonderful being here with all of you. I'm not a WASH expert, neither a nutrition expert, but I'm a public health expert. That's why you may have noticed that I put a little health icon also on my slide. And my vision is that maybe next year we're sitting even with more people together coming from health, WASH, and nutrition part. That would be lovely. I will go through with you very shortly. I have only 5 minutes through a program, or 7, thank you. Through a program we have implemented from 2012 to 2015 in northwestern Cambodia in 2 provinces, which is Siem Reap and Otte Menchai. Maybe some of you are familiar with those, with this region. It was a food and nutrition security program with a focus on women and children. And this program was actually planned for 2.5 years, but it was more or less only 2 years implemented. And I will share with you some of the findings we have from a baseline survey we did and also from an endline survey we did. I think we can skip that one. It's always the same, I assume. Yeah, so just a bit of a background. Malteser International has been in Cambodia since '93, basically since the refugees returned from Thailand, from the Thai camps. We worked in a different kind of areas. We did a lot of leprosy work in the beginning until we handed it over to the government. We did malaria control programs, primary healthcare programs, school feedings, WASH programs, etc., as well as a mother and child healthcare program until 2012, all in the same province. This project I'm talking about has a target population of about 137,000 people in 163 villages in the 2 provinces, so it's very big. And you will see later on maybe it was too big. But the main focus was on Otte Menchai, so the large proportion of the intervention has been in Otte Menchai province. The setting there, it's a French forest area, it's agriculture, heavy agricultural area, with a lot of deforestation, unfortunately, and also there's a lot of migration in this area towards Thailand as well as to Laos. The program was funded by the BMZ and partly by FAO. Yeah, in terms of the methodology, we used a stratified 2-stage randomized cross-sectional survey. The baseline survey was done in August 2012 before we started the program, and an endline survey in 2015 in February, so different season. As you see, one is rainy season, the other one is in the dry season. And the sample population were women in reproductive age. And the instruments we used were a CUP survey, so looking at knowledge, attitude, and practice. A dietary diversity survey, so it's looking basically what kind of food people eat. Do they eat only rice, or do they eat a bit more divert food? And then we used a household hunger scale, so that looks basically if people do suffering of hunger or not. Yeah, so both instruments are very valid instruments and tested also before. And then we looked, of course, to underweight as well as to stunting. This is a bit of a crowded slide. I'm sorry for that. Just focus on the red circles I show you. You will see a bit of, you will see different time frames from 2005 to 2014, where you see quite significant increase of antenatal care by skilled staff, as well as deliveries have dramatically increased, where women actually went to health facilities for deliveries. And you see also an improvement in infant mortality rate as well as under 5 mortality rate. Even for 2014, the figures are not here, but they have improved as well. And for stunting, you will see the second column is actually Ottoman-Chay province, OMC. Yeah, this is the province where we have had the intervention. You will see also a decrease in stunting. Yeah, you will see a decrease. Yeah, sorry, a decrease in stunting. Right. Yeah, here we are quite proud, I have to say, because we have had quite a long period of intervention, especially in the mother and child healthcare sector, and where we have certainly contributed to this improvement of figures, because if you look at the time frame, the program was almost 10 years. We have focused on mother and child health, where we had wash interventions, we had very intensive child interventions and nutrition interventions, and using a community-based health insurance scheme basically to improve access to health facilities. So that is quite a big step in this province for us. In terms of intervention, so we looked at availability of food, yes, by providing or improving the production of food for the people in this area. We looked at accessibility and quality of food, so we provided a lot of home gardens, trained people in home gardening, and we built up fish ponds, livestock. We improved or increased the utility of food, and also through safe water and sanitation system we tried also to decrease the risk for diarrhea, etc. But here I have to say that the whole hardware for the water and sanitation has been done only in 9 villages, while the software has been done in all the villages. So that means hygiene training, etc., has been done in all the villages. Yeah, now coming to the result in terms of knowledge, attitude, and practice, we see quite a good improvement in knowledge, and also putting things in practice. For example, diarrhea prevention knowledge has been increased, as well as the courses that people know. The courses for undernutrition has increased. People started to do their own drinking water or safe drinking water. Washing hands has been improved, etc. In terms of the dietary diversity score, here we see only a very, very small increase of only 1 score. So that means people still eat their food or eat their food what they have done before. So there was not the diversity of the food ration has not really changed too much. And in terms of household hunger, in terms of the household hunger scale, we see that more people now report that they have suffering from little to no hunger. So there was a quite big improvement of about 30%. And there was a slight decrease in severe hunger from 9 to 7%. So not too much on that front. Yeah, what were the challenges for us, and which result have been a bit disappointing to us? This is what you see now, is the exclusive breastfeeding that has dramatically decreased, I would say, for various of reasons. Underweight has increased by 3 to 5%, and stunting, the last one, has even increased by 10%. That was, of course, disappointing for the program, but here are some facts or some issues we have discussed in the team. What could be contributing factors? Of course, with such a survey design, it is very difficult to make concrete kind of suggestion what has been the issue, why we have not been so successful in that part. One is, for example, there was a big flooding in 2013 with a drought in the following year in the same area, which had, of course, an impact on agricultural production, on water availability. So that could be partly an issue of decreasing the production as such. Migration is a big issue in this province. Many people are leaving regularly into Thailand, partly also into Laos for work reasons. So many of them have become daily labor rather than agricultural people. The treatment of severe acute malnutrition was only available in the hospital, at hospital level, and there's only one hospital in this province, or in the two provinces, each has a hospital. So there was no possibility for women, for example, having undernourished child, or to bring those kids to a nearby health facility, especially for the severe acute. Undernutrition is not seen as a problem in Cambodia as such on a political level. It's dealt with like every vertical program, like malaria. There are a lot of vertical programs in the country. Behavior is certainly a relevant factor, and this is we come across in many programs, and we have talked a lot. You mentioned it earlier. Behavior is a huge factor, I think, which needs to be addressed in every sector, in every country. Many things are related to tradition, to norms, etc. To many villages I mentioned already. Then another important aspect we have seen is that often the health authorities are overloaded and overstretched with a lot of vertical programs. Yeah? So we coming in with another nutrition program, with another malaria program, etc., etc. And all the authorities, they get it on top of their shoulder without increasing the number of staff. So it's a huge problem we see in many countries. Recommendations, here I focus basically on three aspects, and then I'm done. Here more on the policy level and also on the structural level. First of all, I think that we need a more multiple dimension approach. For example, we could think of the primary healthcare concept, which has been developed in 78 by WHO, where all different sectors are under one umbrella. Yeah, so to basically bring different sectors together again and bring them under one leadership. And I think we heard this morning the example of Burkina Faso, where many of the sectors are under one leadership. Increase in human resources, I think, is a very important aspect. As I said, that many of the health facilities and the health staff or any other staff deal with nutrition and health and wash, etc. They are often overloaded and overstretched with work, and I think we here have the responsibility, also the donors, to look at this issue. Yeah, often it's not not seen that to support on staff, but I think it is a crucial point we need to address. In terms of technical issues, I think here health needs to be included also. We have seen in our previous project in the same area where we had this strong health focus that things have been very much improved, and the project has unfortunately stopped in 2012, and that could be also an underlying factor that health issues were not really considered here in this program. Mixed method design, I think, is very important. We need more guidance right from the start of implementation throughout programs. I think we discussed it yesterday in Group 2. I think it's a very important aspect to also consider for the future. And lastly, no, not lastly, sorry, donors. I think we need to scale up comprehensive intervention, so that we really looking at the well-being of people and the quality of life people from different aspects. And we have started already actually yesterday to discussing a lot, how we get together and how we can improve those things. Cost-effective studies may help also to guide us a bit more in the future, how we can address things more effectively. And climate change needs to be is a big aspect in Southeast Asia, and also Cambodia is already feeling it right now with droughts, with flooding, with storms, etc. So this is increasing as well, and we all know that people rely a lot on agriculture in Southeast Asia, so we should not forget that. And then on a community level, migration, as I mentioned it already, is a big issue. Focus on low-hanging fruits is a topic I'm like to focus on more. And that is related to behavior change. I think we should think of, if we're not focusing, or if we focus actually on the wrong people, do we have the wrong target group? Shall we not focus on people who are ready to make a change? yeah, who are ready to make the next step and say, now I make a change and now I wash my hands, or now I do exclusive breastfeeding, etc. So that is what is meant with low-hanging fruit, so that maybe we need to be more target-focused, because in society we have different segments. We have people who are ready to want to make a change, to stop smoking, to wash hands, whatever, and we have people who are still considerate, and we have people who have no clue about it. Yeah? So that is what is meant with that. Breastfeeding I mentioned. Food hygiene I think is an issue which we need to also consider more and include in our discussion. And I think, yeah, and basically to look also at small, doable and low-cost interventions in terms of WASH. I don't think we need always to look at the big chunk and big interventions, but small things can also make a big difference. Thank you very much. That's it.
Thank you, Marie, and for bringing that strong health angle into this. I think it is a learning from our side that next time we would have to include more health individuals, and the very specific sort of call for better targeting and so on we'll get to it during the group works later. With regard to time, since that was I will take a question from Oliver, who I see is raising his hand.
Yeah, thank you very much, Marie, for your comprehensive overview of the evaluation. 2 questions. One, how did you finance the study? Because sometimes we have problems convincing the money donors that we need studies like that to demonstrate successful work, especially after the discussions yesterday here also in WASH and nutrition. This is needed. It's felt very much in that room. So finances are a problem. And the second question, you have mentioned you had 9 villages with hardware and all the others with no hardware. Are you able from your data to distinguish also between those? Because that could be very interesting to see the hardware influence in project outcomes. Thank you.
Yeah.
Good question,
Thank you.
everyone.
Yeah. In terms of finance, actually, it was part of the budget. So we had at the baseline, we had a consultant who did the baseline survey, and we used the same survey basically for the end line, which we did ourselves. Yeah. So it was part of the program. And yeah, it's a good question on the WASH intervention. Actually, from our data, we cannot say much. That is the problem with this kind of cross-sectional design, where you can where you can make only assumptions, but we cannot see. We have not, for example, seen any improvement in diarrhea. So the number of the episodes of diarrhea has been very much the same. So there has been no change in that. But that's all basically what we can say. Yeah? Therefore, also I think the intervention was just too small to look at. Yeah.
Thank you very much.
Thank you.
Round of applause, please.